So this morning, I'm very excited to welcome Dr. Sampene, who is from our own division of ASOG. She joined us via McGee Women's Hospital at the University of Pittsburgh, where she completed her residency in OB/GYN. Previous to that, she received her medical degree from the Medical College of Wisconsin. Here at Meriter or at UW, she has really served our department in a variety of different roles, particularly in a lot of leadership roles at the Meriter OB/GYN department. And so she served as the chair of the Meriter Department of Obstetrics and Gynecology, has been involved in Meriter OB quality improvement, and the co-chair of the obesity task force. So in her latest, one of her latest roles, she's now the co-chair of the Diversity, Equity, and Inclusion Committee, and I'm very excited to hear her talk today. So please, everyone, give a virtual welcome to Dr. Katie Sampene.
Thanks, Laura. I appreciate the introduction. So the title of my talk this morning is Leveraging Quality Improvement to Promote Health Equity. I have no disclosures. These are my learning objectives. We'll go over the basics of health equity and quality improvement, and then I'll demonstrate a project application to the QI process. I want to highlight the intersection of QI with health equity and brainstorm new QI ideas. Throughout my talk, I would really like to invite and encourage you to put any ideas that pop into your head for a new QI project into the chat along the way. I'm hoping that we can have some exciting discussion from these new ideas at the end of the talk. So first, health equity. Health equity is something that we have heard quite a bit about over the last year. I'm going to summarize the high points as a brief review. The WHO defines health equity as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. The CDC states health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. As part of our department's 21-day racial equity challenge, I read a blog article by the Equity in Education Coalition. This reframed the concept of health equity. These are depictions to describe health equity that most of us have seen before. While I think the depictions are a good start to understanding the concept, the article I mentioned points out that in these illustrations, someone is tall and someone is short. The short people need variable number of boxes to stand on to achieve a goal. While I don't think intentional, the depiction suggests that the short person has an inherent problem, that is shortness. The problem is part of his or her very being. The article suggested that instead of the people being shorter or taller, the ground is variable with peaks and valleys. All the people are actually the same height. The solution is to try to even out the ground. And while this wasn't in the article, we should end up at a place that is even higher than the current highest peak. If we can achieve health equity, it will actually benefit all people. Take, for example, COVID vaccinations. If we can vaccinate all people at the same rate as the highest subgroups, everybody's health will be elevated to an even higher level than the current high peaks. Since there was no illustration to accompany this concept in the article, my 7-year-old drew these pictures for me. This concept is particularly important to me because the picture on the right represents my immediate family. I'm in the middle with the bun, my husband is on the far left, and our 3 kids are the others pictured with variable shades of skin color between the 2 of us. I will say there was some artistic liberty taken in several characteristics. If you know my family well, My husband keeps saying he's not sure why he has Einstein's hair there. He really has very little. I would like to point out that health equity is not solely about race. It includes other disparities related to socioeconomics, gender, gender identity, sexual orientation, geography, etc. While this talk will tend to focus on race, please keep in mind the many other areas that are ripe for work to promote health equity. When I think about health equity, I think about what the future holds for my family and professionally in my work as an OBGYN. In this report from New York City, it shows me that my daughter won't be immune to the concerns about maternal health as it relates to race. Looking at this top left graph here, you'll notice that the rate of severe morbidity and mortality varies by race and ethnicity. I think about my daughter, and while she may or may not identify as quote unquote 2 or more races, which is the last bar on the right, society will most likely view her as Black. This highlights race as a socially determined categorization rather than a genetic construct. Studies of the genetic structure of human populations continue to find more variations within racial groups than among them. In the remaining graphs, disparities remain despite increasing in education, income, and normalizing weight. This suggests that my daughter won't be able to unilaterally lower her maternal risk, and so it inspires me to work to understand the disparity and to try to remedy it. To bring some statistics closer to home, here's a look at Wisconsin numbers. Many listening today have seen these numbers and figures previously, but I'd like to briefly review. In the top right figure, you can see that 15% of infants born to Black mothers are low birth weight, which is well above the statewide rate. In the bottom figure here, you can see that 15% of Black mothers experience preterm birth compared to 8% of white mothers. Notably, the annual Wisconsin Birth and Infant Mortality Report provided potential rationales for observed inequities. I'd like to take a moment to review this. The 2 boxes depicted here are taken directly from the report. While they're pretty wordy for a PowerPoint slide, and I don't want you to read them right now, I wanted to depict them here to highlight that there's an effort to include a reason behind simply descriptive statistics. It discusses a link between chronic stress and prematurity. It also labels the Black-white difference as an inequity. They do not suggest it as a biologic difference. Rather, they describe discriminatory policies and practices throughout history that have led to less healthy conditions in minority groups. The unequal and unfair hardships and stress throughout the lifespan can lead to worse maternal health and more adverse birth outcomes. I will note here that there absolutely could be genes that predispose patients to poor obstetric outcomes or disease processes. And my talk today is not meant to say that genetic analyses should be abandoned completely. However, given that there is often more genetic variance within races than among them, it is unlikely to be a sole explanation for racial inequities. And we should not infer that an inequity has a genetic basis unless it has proper evidence to support such a conclusion. Commonly, health disparity and inequity are used synonymously, as noted by the wording in the healthypeople.gov site. However, per the Institute for Healthcare Improvement, or IHI, health disparity denotes differences, whether they're unjust or not. Health inequity, on the other hand, denotes differences in health outcomes that are systematic, avoidable, and unjust. There are some differences or disparities as per IHI terminology that are not unjust. By IHI terminology, then, things like sickle cell and cystic fibrosis would be disparities, but not inequities. There may be many topics related to these differences that warrant a health equity lens, but the rates themselves would be considered differences or disparities per IHI, but they would not be considered inequities. And so I kind of made this little chart here on the left if you think about all disparities or differences and ask whether they're unjust, avoidable, and systematic. And if yes, then we would term it a health inequity. And if not, Just a difference or no specific terminology was suggested by the IHI. The social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, policies, and political systems. The social determinants of health have an important influence on health inequities and help shed light on the reasons underlying health inequities. The County Health Rankings and Roadmaps, which is a program of the University of Wisconsin Population Health Institute, works to improve health outcomes for all and to close health disparities. The website's really interesting. It provides health rankings by county for all counties in the US. The program intends to provide data, evidence, and guidance, as well as examples to build awareness of the multiple factors that include health, that influence health, and to support community leaders who are working to improve and increase health equity. From their website, I've taken this figure, which demonstrates the social determinants of health account for about 50% of health outcomes. Clinical care accounts for about 20%, and health behaviors approximately 30%. While this may make us as clinicians feel disappointed about the level of impact that we can have in the clinical care realm, I think it also gives us the necessary perspective to better understand the anticipated impact of any single intervention that we make as clinicians. Recall that one of the social determinants of health, as per the WHO, is social inclusion and non-discrimination. According to the CDC, a growing body of research shows that centuries of racism in this country has had a profound and negative impact on communities of color. The impact is pervasive and deeply embedded in our society, affecting where one lives, learns, works, worships, and plays, and creating inequities in access to a range of social and economic benefits such as housing, education, wealth, and employment. These social determinants of health are key drivers of health inequities within communities of color, placing those within these populations at greater risk for poor health outcomes. In this article published in the New England Journal in August of 2020, the authors described the current situation using race in various clinical algorithms. The article discusses the problem of using descriptive statistics, which aims to describe medical phenomena at a population level as a basis to support an intervention. In medicine, race has long been used as a proxy with the intent of categorizing genetic findings. But if the underlying data reflect racist social structures, then their use in predictive tools cements racism into practice and policy. The authors propose 3 considerations for clinicians when determining if it is appropriate to include race in an algorithm. These are seen in the bullet points above. Number 1 is the need for race correction based on robust evidence and statistical analyses. Number 2, is there a plausible cause of mechanism for the racial difference that justifies the race correction? And number 3, would implementing this race correction relieve or exacerbate inequities? Per the article, in many cases, this appraisal will require further research into the complex interaction among ancestry, race, racism, socioeconomic status, and the environment. However, the article places the burden of the current determination of whether race correction is appropriate on researchers, institutions, and individual clinicians. In this article, the VBAC calculator is examined. Briefly, while the calculator reflects an increased risk of cesarean if African American or Hispanic, there is no plausible causal mechanism. It is worrisome that the increased rates of cesarean may reflect systemic racism, and by its inclusion in the calculator, bakes the inequity into the system. In just a little while, we will consider these questions as they relate to the use of aspirin in pregnancy to reduce the risk of preeclampsia. I wanted to just briefly show this graphic from the UW Health Strategic Plan, simply to highlight that quality and safety and equity are key components and foundational competencies of the UW Health Strategic Plan. It is important to know that this health system places high value on these topics. At this point, we will transition into an overview of quality improvement. To simply define it, quality improvement is a framework to systematically improve the ways care is delivered to patients. Moving forward, I will commonly refer to quality improvement as QI. So what are the origins of QI? In the mid-20th century, William Edwards Deming pioneered quality improvement. He's most known for his work in the auto industry in Japan. He authored the publication Out of Crisis in 1982, and his 14 points outlines the thinking that continues to be inherent to QI methodologies today in healthcare. In 1999, the Institute of Medicine, now the National Academy of Medicine, published To Err is Human. This report brought to light patient deaths attributable to medical error. It broke the silence that has surrounded medical errors and their consequence. It points to designing a safer health system rather than pointing fingers at the individual. Crossing the Quality Chasm, published in 2001, identifies and recommends improvements in 6 dimensions of healthcare in the U.S., as outlined on the following slide. While each of these dimensions are very worthy goals of QI, I'm going to focus on the equity aim today. The 6 aims are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. I'd like to remind you as I move through this talk to please put any ideas that you have regarding QI projects into the chat. The model for improvement is the most commonly used QI approach in healthcare. The model for improvement was developed by the Institute for Healthcare Improvement in 1996. The model for improvement uses a rapid cycle called Plan, Do, Study, Act, which is the PDSA cycle here in the circle. The cycles test the effects of small changes, make them, and ultimately spread the effective changes through the practice or organization. The model for improvement begins by asking 3 simple questions, and those are outlined above the circle. Those questions are: what are we trying to accomplish? How will we know that a change is an improvement? And what are the changes that we can make to result in an improvement? Quality improvement teams then introduced and test changes designed to achieve the improvement aims using successive PDSA cycles until they arrive at a change where they believe it will produce the desired results and ready for implementation and spread. An A3 is a 1-page report that helps you explain the most important parts of the problem and your solution and helps you think through everything you need to be successful. You can think of an A3 as a tool to help organize yourself and your project. It was first developed by Toyota and used in lean manufacturing. The term A3 was the designation for the size of paper that it was done on. You can find a template and simple steps to lead you through the process on UW's UConnect. By searching for quality improvement on UConnect, you can also find an entire host of tools and resources for quality improvement work. At UW, they encourage the use of A3 using the FOCUS PDSA cycle. FOCUS is an algorithm that stands for find a process, organize a team, clarify the current state, understand variation, and then select your improvement. One important point to distinguish is whether a project is QI or research. Generally speaking, QI is meant to bring knowledge into practice as opposed to discovering new knowledge. It uses many sequential tests and gathers just enough data to learn and complete another PDSA cycle, while research tends to use one large test and gather as much data as possible. There is a UW IRB QI program evaluation self-certification tool that is important to perform prior to starting QI. This will confirm that your project is QI and not research. For QI, an IRB is not necessary, and this step will help assure you can legitimately move forward without the need for an IRB. Back to FOCUS PDSA, the F stands for Find a Process to Improve. The 5 whys is useful for uncovering root causes and selecting an improvement to work on while working through the FOCUS PDSA. The theory is that asking the question, why does that happen, 5 times will reveal the root causes that contribute to the issue being addressed. In this example, you can see the 5 whys applied to the problem of too much preeclampsia. If you follow the chart, you can see that too much preeclampsia is due in part to the patient not taking aspirin, which is due in part to a recommendation not being made, which is due in part to not enough time for providers to go through the algorithm, and the algorithm being too complex. Now, in this particular example, we stopped asking why because we reached the point at which we cannot change the response. We aren't going to take on trying to change the USPSTF algorithm for aspirin recommendations, and for a number of reasons, we did not plan to seek more provider time in the new OB visit. If you cannot reduce the complexity or get more time for the visit, it is necessary to brainstorm creative ways to perform complex screening in a short period of time. A fishbone diagram is another way to determine cause and effect and would be an alternative to the 5 whys. It's a visual diagram and it represents a fish. The head indicates the particular problem being analyzed, and then the bones are the potential causes. Once you have identified a root cause to address, you want to develop your aim using the SMART framework, which is specific, measurable, achievable, realistic, and timely. This allows you to assess the scale of your intervention and to pare it down if your original idea is too ambitious. An example of a specific aim is we will increase the percent of the aspirin recommendations made for those eligible from 25% to 95% by October of 2021. There are 3 main categories of measures. There's outcome measures, process measures, and balancing measures. Shortly, we will be considering the example of a project to implement a standard screening process for making recommendations regarding which patients should take aspirin to reduce the risk of preeclampsia. An example of an outcome measure would be the percent of patients with preeclampsia. It is the patient outcome in which we are interested. An example of a process measure would be the percent of eligible patients that received a recommendation to take aspirin. This is a measure assessing one step in the process to achieve lower rates of preeclampsia. Balancing measures are less obvious. These are the measures to assess new and unintended problems that the intervention could pose. An example of a balancing measure would be the amount of time for the intake visit during which the screening for aspirin recommendation is done. I want to just briefly mention considerations for assembling an effective QI team. One person could fill multiple roles, or you may need multiple people to fully represent one line item. You want to make sure you have the proper leadership, expertise, and sponsorship. You want to be sure you have important stakeholders, including patients or non-clinical individuals, if applicable to the project. In brief, you want to be sure you assemble all the people you need to achieve success, both immediately and to achieve a sustainable future result. The success of the project can depend greatly on having the right people at the table, and certain team members may be part of the team for only discrete points in time of the project. Challenges one can expect with QI include convincing others your idea is worthwhile and creating a sustainable process. There will always be issues with competing priorities and a shortage of time. Obviously, QI is intended to benefit the patient in terms of safety, quality, effectiveness, and experience. That being said, I don't want to ignore that the team can greatly benefit from these endeavors as well. For both trainees and clinicians, it is a chance to improve care. Individuals can develop leadership, presentation, and time management skills to help their career development. It also provides opportunity to build relationships with both colleagues and organizations. I really like this quote about QI that was made by Dr. Mike Evans, a professor of medicine at the University of Toronto. Don't let what you can't do stop you from what you can do. Take time to entertain complexity, but focus on simplicity. Ask yourself, what can you do by next Tuesday? Sometimes for me, thinking about health equity, social determinants of health, and systemic racism gets me bogged down. It feels like solving world peace. I'm not even sure what I can do differently as a physician to reduce the rates of preterm birth or growth-restricted fetuses. I keep seeing statistics, but I don't know what I can actually do to solve the problem. I think QI is one way to make meaningful change towards a goal of health equity. No single little QI project will produce health equity. In fact, even if the entire medical field operated at the level of perfection, we won't solve health equity due to the other components we previously discussed, including social determinants of health and health behaviors. But if many people do one small thing, it could really add up. QI is one way to make a systemic contribution in a tangible way. At this point, I want to lead you through an example of a QI project. In June of 2020, Dr. Kathleen Ireland presented a grand rounds regarding cardiovascular disease in pregnancy. She highlighted racial disparities for cardiovascular disease in pregnancy, particularly for Black women. She also reviewed the United States Preventative Services Task Force recommendations, which ACOG supports for triaging aspirin recommendations in pregnancy for the reduction of risk in preeclampsia. Dr. Ireland's presentation highlighted a great area for improvement from my personal practice. It was very obvious that I was missing the mark on this standardly accepted recommendation. After a robust discussion in the question and answer portion of that grand rounds, resident Maya Gross and medical student Ainsley Timmel reached out to me to further explore the ways in which we could work together to reduce health inequities. Out of this discussion evolved the project I will now discuss. Now I'm going to take a minute to delve into the background of the top line here. What are we trying to accomplish? A general aim could read as reduce the risk of preeclampsia or to reduce racial inequities in the rates of preeclampsia. However, using the SMART method for developing a goal, a specific aim can be developed. A specific aim could read UW-ASOG will increase the percent of the aspirin recommendations made for those eligible from 25% to 95% by October of 2021. I'm going to step back from the model for improvement for a moment and provide some background regarding the use of aspirin to prevent preeclampsia. The USPSTF published this clinical guideline in 2014 recommending low-dose aspirin for the prevention of morbidity and mortality from preeclampsia. Low-dose aspirin functions by diminishing platelet thromboxane synthesis and potentially by modulation of inflammation. Preeclampsia is the second leading cause of maternal mortality worldwide. 12% of maternal deaths are directly attributable to preeclampsia, and 1/3 of severe obstetric complications are related to preeclampsia. It causes 15% of preterm births in the US. The USPSTF report recommends risk stratifying patients based on the characteristics noted in the box here on the right. Once the screening is complete, the clinician needs to determine whether the patient has elevated risk and warrants an aspirin recommendation. Elevated risk is deemed an 8% or greater risk of developing preeclampsia. Baseline risk of preeclampsia in general in the US population is typically quoted to be around 3 to 4%. A patient can be recommended for aspirin if one high risk factor is present in the box here on the top, or if 2 of the moderate risk factors are present in the middle box. When thinking about properly recommending aspirin, we need to think about why we are not currently successful in accomplishing this. Reliably and consistently remembering all of these risk factors is difficult, and it takes time. Providers may also be unsure of the magnitude of the benefit of making the recommendation to take aspirin. So I'm going to talk about that next. The USPSTF found evidence that aspirin prescribed to those at increased risk of preeclampsia affords a 24% reduction in the risk for preeclampsia. This was determined as a pooled risk from 13 studies. There was also a reduction in preterm birth by 14%, and IUGR by 20%. The absolute risk reduction is 2 to 5%. You may be wondering how to make sense of these numbers and to put them into context for patient counseling. They can be described as follows. For the patient who meets the USPSTF criteria for an aspirin recommendation, taking aspirin can reduce the risk for the individual of developing preeclampsia by 24%. This means that, roughly speaking, if your estimated risk of developing preeclampsia is 20%, by taking aspirin, you could reduce the risk to 15%. If your initial risk of developing preeclampsia is 8% when not taking aspirin, then taking aspirin can reduce your risk to 6%. The minimum risk to be considered elevated risk by the USPSTF algorithm is 8%, which is determined by the risk factor stratification chart. I'd like to take a moment to go through some of the probing questions posed by the New England Journal article Hidden in Plain Sight. My first question when considering whether race should be included in this algorithm is to confirm that Black or African American patients are, in fact, at an elevated risk of preeclampsia. I would like to pause here for a moment to acknowledge that the terminology of Black and African American are not equivalent, but are not well delineated in most research studies. There are Black people living throughout the world. African American denotes individuals of African descent living in America, and usually, but not always, in reference to descendants of enslaved Black people in the United States. The USPSTF uses the terminology African American. Keeping in mind race as a social construct, an individual may identify differently than the ways in which society tends to classify individuals. The USPSTF does not comment on the nuances of the terminology choice. Not all studies have shown a higher rate of preeclampsia for Black or African American patients in the US, but most do. In this study, the graph noted here depicts the rate of preeclampsia in women in New York from 93 to 02. You can see on the top line that the rate for Black women ends at the 2002 data point of 3.4%. It's fairly stable over time. The rates of white women are depicted by the bottom line, ending at a rate of 1.7% and are declining. It is notable that the overall prevalence of preeclampsia in this population appears to be somewhat lower than national averages. In this article by Tucker, assessing the Black-white disparities in maternal health suggests that while the prevalence rates for preeclampsia are actually similar, the mortality rates are higher for Black women. The difference in prevalence of the diseases in this study did not meet statistical significance, but do trend toward an increased prevalence in Black women. However, the case-fatality rates were statistically significant. At this point, you may be wondering why African American women are at increased risk for preeclampsia. According to the USPSTF, it is related to disparities in risk factors, limited access to prenatal care, and obstetric interventions. Notably, the USPSTF does not discuss the potential impact of chronic stress related to systemic racism and/or other social determinants of health. However, they are working on an update to the 2014 guidelines, so it will be interesting to see what changes are made to the publication in light of newer evidence. Recent studies of women identified as having African ancestry are observed an increased risk of preeclampsia when the mother carried a particular HLA antigen, contributing to maternal immune tolerance and successful placentation. There have also been single nucleotide polymorphisms related to angiogenesis between Black and white women associated with preeclampsia. While there seems to be some associations with genetic variations, genetics has been a far cry from a full explanation of the disparity. A fuller understanding of all the possible etiologies is necessary to work towards fixing the disparity, as it is apparent that no single explanation that's just easy in explaining it really exists. Circling back around to the article Hidden in Plain Sight, I want to think about their questions again. The first question asks whether there's a need for race correction based on evidence. I would affirm for this question that there is robust evidence that the inequity exists. However, we do not have evidence that aspirin will fix the inequity specifically, but rather evidence that it reduces the risk of preeclampsia. In the second question, there are a multitude of plausible causal mechanisms, though no single mechanism is very likely to explain the inequity in itself. Aspirin is not a specific intervention to a causal mechanism of the inequity, but rather targets a causal mechanism of preeclampsia. The third question asks whether aspirin will exacerbate or relieve the health inequity. Aspirin is expected to relieve the inequity. In summary, while this is not clear-cut, it appears reasonable to include race in the USPSTF table. According to the USPSTF, there is no harm associated with aspirin in pregnancy. According to the Cochrane review, there is probably a small increase in EBL greater than 500 cc's and a small increase in the risk of abruption. However, evidence was downgraded to moderate due to heterogeneity in collection and low numbers, respectively. We have discussed that the basis for the recommendation for aspirin is that the individual is estimated to have an 8% or higher risk of preeclampsia. The USPSTF states that the table we have reviewed is a pragmatic approach and that clinical risk assessments were not systematically reviewed for this recommendation. While the table serves as a guide, I think it would be appropriate to use clinical judgment in certain circumstances. You may be wondering at this point whether aspirin should just be given to all pregnant patients. Two cost-effective analyses looked at this question. The study on the left showed universal aspirin to be superior to the USPSTF algorithm. This assumed that there was no harm caused by aspirin. In the study on the right, the cost effectiveness was similar for the USPSTF and universal aspirin strategies. They did, however, consider potential harms, including abruption, which the authors on the left did not feel was supported by the data. There are also a host of assumptions that are made when determining cost effectiveness. Nonetheless, both strategies showed that the USPSTF algorithm was superior to not prescribing aspirin. It has been suggested that an opt-out strategy would be a better public health strategy than an opt-in strategy by complex screening. We may find in time that the opt-out approach gains traction. However, at this time, without any major organizations supporting a universal approach, it is unlikely to be one that will be employed by large groups or systems. Now that we better understand what we want to accomplish, we move on to the next box. To know that a change is an improvement, we plan to collect 20 charts each month to analyze the percent of eligible patients receiving an aspirin recommendation. We plan to create a run chart and monitor data to continuously assess for improvement. We will discuss this further in the next few slides. Next, we move on to the actual change. With the 5 whys or the fishbone diagram, we elucidated that the algorithm was too complex and that there was not enough time in the new OB visit to do this. Therefore, we needed to leverage more staff to help with screening and streamline the process. We propose that the RN will screen the patient with the standard USPSTF tool at the new OB visit. The score would be added to the designated category in the problem list, and the RN would pen the aspirin order according to the algorithm result. The provider would then have the necessary info easily accessible to determine and make an appropriate recommendation to the patient. We then moved on to the P, or plan of the PDSA cycle. We met with a nursing leader and provided clarity regarding how to screen using the USPSTF task force chart. We made clarifications to the chart to make it user-friendly. We specified that when determining African American race for the questionnaire, that it should be by self-identification, and the nurses were explicitly instructed on the chart to use the patient's self-ID designation from EPIC. We reviewed the plan with ASOG physicians and residents. We built in EPIC smart phrase for the RN to use and updated the problem list to include the aspirin fields. The do or the D is when we implemented the change in January of 2021. Next, we move on to studying our data. I mentioned that we had decided that we would know that a change was an improvement by analyzing 20 charts per month to assess the percent of eligible patients that received an aspirin recommendation. You will note that the pre-intervention median was about 25% for the percent of eligible patients receiving the recommendation for aspirin. And this is denoted by the red line on the left side of the graph. The left side reflects 10 months of time in 2019, which was chosen due to wanting to avoid the confounder of COVID. Starting with month 11, which was January of 2021, when we implemented the change, our median percent of patients that received the aspirin recommendation was 92%. This type of chart is called a run chart and is specific to quality improvement. This is one way to monitor for continuous change over time. I would like to draw your attention back to the difference between research and QI. At this point, I'm going to tell you a mildly embarrassing secret. We started out with a plan for a single intervention and a pre-post analysis to see how we did, meaning we basically used this research approach initially. You will note that the QI typically and traditionally employs many sequential tests, and the run test is typically what is used depicted in this chart below. Research is what typically does this one pre and post intervention assessment. While you may obtain similar information in the end, the run chart and rapid cycles of gathering just enough data to learn and complete another cycle is generally a faster way to achieve quality improvement. In this particular straightforward project, it may be harder to see why a continuous data collection approach for change is better. If you are still wondering, I think I'll be able to clarify that for you in a few slides. In this article by Golden, the differences between traditional quality improvement and rapid cycle quality improvement is described. The main takeaway concepts that I'd like you to note are that small, quick changes can be done to test improvement. For example, it could be that you are going to test on just one provider for one day. You do a quick PDSA cycle and see if it works. Then, if it works, your change can be spread to sequentially larger populations, perhaps one clinic site or one group such as ASOG. Our study portion suggests that we made good improvement. However, we also want to see why we didn't quite make the 95% goal. Studying the problems that arose with our intervention, we realized we needed to provide clarity around several things. For autoimmune disease, the intent was to limit the recommendation for aspirin to those autoimmune diseases such as lupus or antiphospholipid that confer an increased rate of preeclampsia. However, we realized women with autoimmune diseases such as Crohn's were also receiving this recommendation, requiring clarity to our nurse smart phrase chart. Similarly, nalipurity caused confusion with the nurses as to whether women with prior miscarriages were paris or not. Therefore, we plan to clarify this question to indicate no prior births greater than 20 weeks. We also noted that IVF pregnancies were being missed on the scoring process, and we also plan to change the wording of ART so that it is better clarified. Additionally, we found that some nurses were not pending aspirin prescriptions. This may be happening when patients prefer to purchase the medication over the counter. We are considering changing the wording in our smart phrase from a yes/no dropdown to whether the aspirin prescription was pending to include more choices such as a historical medication being added. Finally, we would like to consider adding the provider plan in the new OB note as a numbered field to address aspirin for risk reduction of preeclampsia. Some of the providers have added this to their template, and it appears to be helpful in jogging the memory of providers to make the recommendation. As ASOG works on a project to standardize note templates, this will be an important thing to keep in mind. The A, or acting, would be implementing changes to the data we found during the study activity. This is the phase of the cycle that we are currently at in our project. I'd like to circle back around the depiction of health equity. I would like to provide a word of caution for implementation of QI projects to promote health equity. There are many well-meaning interventions that could lead to greater disparity. For example, consider this aspirin project. What would happen if there was good patient compliance for white, high-income individuals and lesser compliance for African-American individuals? Would it be because doctors aren't as strong in the recommendation made to African-American women, or because of difficulty obtaining the medication, or perhaps a cultural wish to avoid medication in pregnancy? While this is an entirely hypothetical situation, I'm intending to illustrate the need to carefully consider the QI project and the potential ways in which it could unintentionally widen a disparity. So far, I've only used a process measure of percent of eligible patients receiving a recommendation. However, it may be important to consider compliance in the future. This could also lead to a research project in the future to determine the actual preeclampsia risk reduction for African American women taking aspirin. To summarize, it is important to avoid unintentional widening of disparities. In this retrospective cohort study, the incidence of recurrent preeclampsia was studied before and after the 2014 USPSTF recommendations. The risk of recurrent preeclampsia decreased by 30% in the after group. The risk of recurrent preeclampsia in the Hispanic after group was lower, but in the African American group after group, it was actually higher. The authors report that they cannot state whether these observations are due to under or overpowering. The authors state, quote unquote, that these findings potentially suggest that there may be racial and ethnic variation in responsiveness to low-dose aspirin prophylaxis for recurrence of preeclampsia. It is interesting that in this study, there was no attempt to assess aspirin recommendations or compliance. It was strictly a pre-post USPSTF recommendation for the observation of rates. While the authors acknowledge this in another area, they do not link it directly to the question of race and ethnicity. I think this illustrates for me that if we are not careful, we can easily fall into attributing phenomena of descriptive statistics to race, suggesting a genetic component alone, when in reality, it may be related entirely or in part to other factors as well, including bias in recommendations, disparities in compliance, etc. Sources to consider new ideas include publications and personal experience. For example, the Saving Our Babies report recommended implementing screening for domestic violence at every patient intake, particularly but not exclusively in pregnancy, with the goal to identify, intervene, assist, and refer to appropriate support and protective services. This would be a great QI project. Ideas for QI can also come from your clinical experiences. I experienced an impactful case in which an African American woman attempting a TOLAC required an unscheduled cesarean. Due to suboptimal communication among the healthcare team and the support person, tensions became very high in the operating room and led to a near miss. It has led me to believe that there is room for systemic improvement in communication, particularly for Black patients who may have less experience with and less trust in the healthcare system and are undergoing the highly stress-inducing events of an unscheduled cesarean. You can probably understand, however, that one's ability to elucidate the root cause and create an appropriate intervention may be much more challenging compared with a project to implement screening for domestic violence. Using the QI framework, however, can help guide one in tackling this type of work. For me, I see the importance of health equity in the care of my patients and in my own family pictured here. Like all patients, I would like the world to be a better place for my children. Like all doctors, I would like my patients to be healthier and have better health outcomes. A colorblind approach of trying to treat all patients the same amount of nice is not effective. An individual reckoning of minimizing bias is also unlikely to be unilaterally effective. If racism is a systemic problem, then seemingly systemic solutions would be most effective. While equalizing the social determinants of health may be the most effective way of promoting health equity, we are in the field of health care. Leveraging quality improvement is one way of approaching a systemic problem with a systemic process. Quality improvement won't be the only fix for inequities, but it can be a piece of the puzzle of the solution. I'm also hoping that I can inspire and encourage our students and residents listening today to embrace QI as a meaningful part of their learning and careers. Fortuitously, Dr. Katie Anthony will be heading a QI program for residents in this upcoming academic year, and I hope that we can continue to leverage QI and to promote health equity. I have many individuals to thank, starting with Dr. Rice. I'd also like to give particular shout outs to Dr. Maya Gross and Ainsley Timmel, as well as Nurse Welts, who are key to launching the Aspirin QI project. I'd also like to thank Dr. Makeba Williams, who's been a mentor to me and has pointed me in the right direction on many occasions. Thank you to everyone, and I'm happy to take questions.
Katie, as I put in the chat, I just learned a ton. Sorry, echo here somehow, but thank you. That was I really, really appreciate you pulling this talk together. And I appreciate your leadership with DEI. You're just really, I feel quiet. Thank you.
Yeah, absolutely. Thank you.
Hi, Katie. That was an outstanding job. I think that we also need to look at the cardiovascular risk assessment tool being embedded into our electronic records. A lot of people don't realize that I left Chicago. I was paid a tremendous sum of money for a longest term contract that they have for an OBGYN in advocate healthcare. And I walked away after 2 years because I saw blatant healthcare investments and disparities in the system. It got to a point, to be honest with you, where I went down and found a powerful lawyer to try to fight advocate healthcare. But they said I couldn't afford to pay for them. Racism is systemic. And every Black hospital that serves predominantly Black people that I've worked at has substantial challenges. One of the problems was that I walked out of residency working at Northwestern, and I saw that these problems did not have to exist. And so that for people that say, oh, this is just a kind of passing phase, maybe it'll kind of blow over and da-da-da-da, it's not going to blow over. We've got to do something about it. Every African American, almost that I know, I mean, I got to look at something else. My cousin is a pilot that deals with this stuff in the aviation industry, is dealing with problems. It's just insanity. And I do watch for those aspirin patients when they come to triage, because by taking care of majority Black folks most of my life, I've looked at trying to prevent them from getting preeclampsia, but I also look at everybody that comes in for risk factors that should or shouldn't have been on aspirin. So I'm glad that your project is accomplishing an improvement in aspirin use among all of our patients, because our goal is to have equity amongst everyone.
Absolutely. Thanks, Luther.
I like to also, if nobody else is going to say, that we have more of a colorism problem in America. It's not genetics. African Americans are mixed with a variety of different genetic influences. But the first thing that people see is Black. And the Blacker you are, the worse that sometimes they interpret you. And so I looked at a New England Journal of Medicine article the other day of a African American physician who was Miss Obama's OBGYN, and she was talking about somebody at her a job that she knew on an everyday basis that grabbed her purse when she walked up to her outside of the hospital environment, and so that we just need to make sure that when we're looking at these studies and things like that, sure, some of these folks may not be completely African American. None of us are. And the vast majority of people that are over here in America did come from Africa. We kind of didn't just kind of crop up from the Native Americans. But the reality is all people are from Africa, and most anthropologists do not dispute that fact, probably from Eastern Africa. So that we just have to figure out a way of looking at people as people instead of just putting a color on it, because it's a phenotype, the color. We don't really know what the underlying genetic influence, because some people you see as Black actually are more white than Black.
Yeah, absolutely. It's the spectrum and various mixes, and it ends up being, as we've learned, kind of largely a social construct and less genetic based.
Well, if nobody has any other comments, I want to thank you again, Katie, for everything. We're so lucky to have you in the department. And anybody have anything else they want to add? Okay. Listen, have a great day.
Thanks for having me.